focus more on upfront therapy in my talk. And we've already seen this slide this morning, perhaps several times, but just to remind you that obinutuzumab, or GA101, is a type 2 anti-CD20 antibody. It confers increased direct cell death, which is non-apoptotic and involves actin polymerization and likely is lysosomal mediated. And it also confers enhanced ADCC due to glycoengineering that increases affinity for Fc gamma R3A. However, it has lower CDC activity. So the remainder of the talk is focused primarily on two trials, CLL11, which we've already heard about at length, so we'll move through quickly, and then the Galton study, which is a phase 1b study of obinutuzumab with FC or with bendamustine, which will prove a nice counterpoint to the discussion that started earlier. So to remind you again, CLL11 was a registration trial for obinutuzumab in combination with chlorambucil run by the German CLL study group for previously untreated CLL patients with comorbidities. And it was a 2-to-1-to-2 randomization, so the chlorambucil arm had fewer patients. There's initial stage 1 analysis, antibody arms versus chlorambucil alone. Stage 2 analysis compared the two antibody arms to each other. There were 330-odd patients randomized per arm. The efficacy analysis included 663 patients and safety analysis 657. The baseline patient characteristics are generally well matched, and as we just saw with complement, the median age of the patients is much more typical for our CLL population, up in the 73 to 74 range. Sears score was 8, so the patients did have comorbidities. And in terms of creatinine clearance, it was actually reasonably well preserved, with only a quarter of the patients less than 50. The adverse events of interest in particular included infusion-related reactions. And I'm sure, as most people are aware, infusion-related reactions with obinutuzumab are significant, and I'll show you some more nuanced data on that later, but can generally be managed by splitting the dose and using highly potent corticosteroids in addition to diphenhydramine and Tylenol. And as expected, those were increased in the G-chlorambucil arm compared to the rituximab chlorambucil arm. Neutropenia was fairly well balanced in the arms, however, as were infections and pneumonias. Response rates we've already seen were higher with G-chlorambucil versus R-chlorambucil, as were complete remissions. And the Germans presented this data on minimal residual disease, which was only assessed in a subset of the patients and was assessed at the end of treatment response time, which means that the peripheral blood data are perhaps somewhat suspect, as we know that particularly within 6 months of monoclonal antibody, MRD testing in the blood can be artificially negative. But we see also that in those patients who underwent MRD testing on bone marrow, which were primarily those thought to be in complete remission, there was a higher incidence of MRD negativity with the G-chlorambucil compared to the R-chlorambucil. We've seen the progression-free survival, 27 months with G-chlorambucil versus 15 months for R-chlorambucil. The subgroup analysis showed that this was a uniform benefit across all patient characteristics, with the exception of the fact that in 17p and other cytogenetics, these groups had only 40 patients, and so the confidence intervals crossed 1, although the trend of benefit was similar to what was seen in the other subgroups. Overall survival, again, was improved by G-chlorambucil compared to chlorambucil alone, but not compared to R-chlorambucil, at least as of this follow-up. So in summary, G-chlorambucil as a first-line treatment of CLL patients of rather typical age and with comorbidities showed an acceptable safety profile. It prolonged overall survival in comparison to chlorambucil alone, was superior to R-chlorambucil with respect to progression-free survival, CR, and MRD negativity. This does suggest that the type 2 character and glycoengineering of GA101 may improve anti-CD20 therapy in CLL, at least compared to rituximab. We don't have head-to-head data compared to ofatumumab, as you know. And then, as was discussed earlier, it does suggest that the induction of deep remissions in even CLL patients with comorbidities who are older may change the course of CLL, in that many of these patients are potentially dying of their disease and better therapy may help. So now I wanted to talk to you about the results of the Galton study, which was a phase 1b parallel cohort study, also in previously untreated CLL patients. But these are the fit younger patients. 41 patients total were enrolled. There were 2 parallel cohorts. This was not randomized. And in fact, a given center selected one arm to participate in. So different centers participated in different arms. There was a GFC arm in which 21 patients were enrolled, and a G-Benda arm in which 20 patients were enrolled. And the dosing was typical for upfront therapy. The GA101 had split dosing with 100 milligrams on day 1 and 900 milligrams on day 2, again, to help mitigate infusion reactions, which are primarily first-dose reactions. And the fludarabine, cyclophosphamide, and bendamustine were given at standard initial therapy doses. So the baseline patient characteristics are shown here. Patients were about 60, as is common in the studies of more fit populations. Median time from diagnosis was 2 to 2.5 years. About a third of patients had advanced stage disease. And you'll note that the total lymph node burden was higher in the GFC arm than the G-Benda arm, although this is not comparative. In terms of biologic features of the CLL, there was one patient with 17P and 4 with 11Q enrolled on the GFC arm. That amounts to 30% of that arm, and 2 11Q patients on the G-Benda arm. And about 45% of patients were unmutated in both arms. So in terms of patient disposition, again, 21 patients on the GFC arm, 7 discontinued treatment prior to the planned 6 cycles of therapy, all due to adverse events, which we'll review, and 14 patients completed a full 6 cycles. On the G-Benda arm, 20 patients were enrolled, and 3 discontinued treatment, 2 due to adverse event and 1 due to physician decision, with 17 completing the full 6 cycles of therapy. And the median observation time was 11 to 14 months, depending on the arm. So the mean number of treatment courses delivered was 5 for GFC, which is not so different with what we've seen with FCR in large multi-center trials, and 5.5 for G-Benda. The full expected dose of obinutuzumab was given in both arms, namely 8 grams, because again, it's given on day 1, 8, and 15 in cycle 1, which is pharmacokinetic-based dosing to achieve a more rapid early level of the drug. And the median cumulative doses of chemotherapy delivered were approximately 90% for both the FC and for the Benda. Now, patients who needed a dose delay of more than 14 days to meet criteria for treatment were required per protocol to discontinue therapy. And so at the bottom, you can see patients with a dose delay of less than 14 days per cycle who were allowed to continue on therapy. And there were generally several distributed across each cycle of therapy. Adverse events leading to treatment discontinuation are shown here. And again, there were 7 on the GFC arm. There were 3 very early events within the first 2 cycles. One patient actually developed grade 4 transaminitis following only 100 milligrams of obinutuzumab infusion, and per protocol was required to discontinue therapy. The other 2 patients developed grade 4 cytopenias, one with concomitant cellulitis and came off therapy in cycle 1, and the other developed cytopenias in cycle 2 and came off therapy. The other 4 patients who discontinued were primarily due to cytopenias later in therapy at cycle 4 or 5, when we often see that as well with FCR. I would note that only 62% of patients on the GFC arm received any myeloid growth factor at any point during the study for either prophylaxis or treatment, as this was left to investigator discretion in the study. The G-Benda arm, 2 patients discontinued early, both for neutropenia, 1 at cycle 2 and 1 at cycle 5. So this slide summarizes the grade 3/4 adverse events by arm. 85% of patients on each arm approximately had some grade 3/4 event. These were predominantly hematologic. You can see about 50 to 60% of patients had grade 3/4 neutropenia at some point. Thrombocytopenia was lower, anemia also lower. Infections, there were 4 grade 3/4 infections on the GFC arm, but this rate of 19% is not worse than we saw with CLL8, and earlier today we saw 39% with FCR and CLL10. Again, this is a very small study, so it's difficult to assess any true rates of these events. And then one thing that was noted was that transaminitis was seen in the GFC arm, all of which was self-limited, none of which was related to hepatitis. And it did appear to be distinct from what's been seen with FCR potentially. In the G-Benda arm, mostly the cytopenias and other events not so notable. So this slide summarizes the infusion-related adverse events, which I alluded to earlier. And as we typically see with obinutuzumab, they're primarily cycle 1, day 1 events in which most patients had some level of infusion-related reaction. There were grade 3/4 infusion reactions in both arms, all confined to cycle 1, day 1. And for the G-Benda arm, 3 of these were reported as SAEs, although none were reported as SAEs for the GFC arm. There were no further grade 3-4 events after cycle 1, day 1, however. And this is not dissimilar from infusion-related reactions seen in other obinutuzumab studies. So the end-of-treatment response rates are shown here. And so on the G-Benda arm, the overall response rate was 90%, with 20% CRs and 25% CRIs, or 45% CR/CRI, which looks nice. On the GFC arm, the overall response rate was 62%, with 10% CRs and 14% CRIs, which of course looks somewhat low compared to what we expect to see from known FCR data. I would point out that this being a very small study is one issue. Another issue is that there was a significant amount of missing data. You'll note 4 patients at the bottom, non-evaluable or missing. This was due to the patients who discontinued therapy early without response evaluation, as well as a couple of patients that did not undergo the required CT scanning to call a response on the protocol. The other thing that stands out here is 4 patients with stable disease, which is not so common, typically in FCR studies. But again, 3 out of 4 of these patients did not undergo the full response evaluation per protocol that was required to call even a PR, and were assigned stable disease. And so there are a number of patients perhaps not fully evaluated in that 62% number. And again, a very small study, so confidence intervals for all of these numbers are very large and largely overlapping. So in looking at the duration of treatment and follow-up on the GFC arm, no patients progressed during the median observation time of 11 months, and 14 patients on this arm underwent bone marrow biopsies. 13 of those were clear of any evidence of CLL, including standard clinical flow cytometry. The multi-center effort to look at minimal residual disease by 4-color flow ended up not being entirely successful, as there were some samples that did not arrive, and ultimately not enough events were able to be evaluated. So it was only at the 10 to the minus 2 to 10 to the minus 3 level. You can see 6 of 9 patients on GFC and 15 of 16 on G-Benda were said to be MRD negative by, again, only 10 to the minus 3, and this was also on peripheral blood early after treatment, which, again, can be confounded by the antibody. In our individual center, we had 9 patients treated with GFC. They had bone marrow biopsies, which were all uniformly negative by 10 to the minus 3 flow. And then we did test in peripheral blood MRD negativity at more distant times, generally at least 6 months out from therapy, for MRD negativity at 10 to the minus 4 level, and you can see that all of those patients were negative. On the G-Benda arm, no patients progressed during the median observation time of 14 months, and 14 of the 14 bone marrow biopsies done on this arm were clear of disease. All right, so in summary, CLL11 demonstrated that obinutuzumab chlorambucil was superior to rituximab chlorambucil in untreated CLL patients with comorbidities with respect to response rate, CR, MRD, and progression-free survival, not overall survival as of this follow-up. And the phase 1b data in combination with bendamustine and with FC, I think, provide at least preliminary data that these regimens are safe and effective. However, I agree with both the comments earlier that I don't think they're ready at all for clinical practice yet. I think the data demonstrate that they justify a somewhat larger trial. The events of neutropenia that resulted in early discontinuation from therapy are certainly events that we also see with FCR, and it's very hard in this small study to know if they were just patient selection or if in fact there are greater rates of early neutropenia. And so I think we would need a larger study to fully understand that safety profile as well as the efficacy profile in comparison to rituximab combinations. And then there will be upfront single-agent data comparing obinutuzumab 1 gram versus 2 gram doses at ASCO later this year.